Dr. Raghu S Thota is currently professor in Tata Memorial Centre, is corresponding author of the first Indian cancer pain management guidelines. He has more than 40 publications and authored many textbook chapters. He has been awarded the Navaratna Award, Vaidya Ratna National Award, and Guinness World Records Certificate. He is the founder secretary of Society of Onco Anesthesia and Perioperative Care. He is also an executive member of ISA Mumbai and IDA Mumbai.
Thank you very much.
Yeah, so few inputs have come. One of the psychiatrist, Dr. Srivatsa, has written about in the chat box the evidence of duloxetine in cancer institute neuropathic cancer-induced neuropathic pain is useful to neuropsychiatrists working alongside oncologists in helping patients with cancer.
Yes, that is there. I already told that duloxetine is the only drug which is recommended, and that drug we use. But most of the times, in our institute, most of the patients do come, they don't afford duloxetine because it is a bit expensive drug compared to amitriptyline and nortriptyline. So we do give duloxetine, and that's the only drug which is recommended.
All right. And Dr. Amrita wants to know, can you please mention the magic mouthwash once again?
So the magic mouthwash I was telling you, it contains of syrup Gelusil. Okay, then it contains of syrup Benadryl, then it contains normal saline. And sometimes we do add, lignocaine is also added in that. And sometimes we do add morphine.
That's a very enlightening talk, Dr. Raghu. I do come across this post-chemo and post-radiation challenges, which I considered is a real gray area in cancer management. Like we know about visceral pain, we know about blocks, but sometimes we get stuck totally with how to go about the post-chemo, post-radio induced pain. And
hello, sir. Can I have one question to sir?
Please,
yeah, please.
Hello, can I proceed?
Yes, yeah, we can hear you. Please.
Yeah, sir. Actually, I wanted to know what is the role of low-level laser in treating oral mucositis, because there are many journals out in Western countries and even in India, few hospitals are using this low-level laser, that is photobiomodulation therapy in treating oral mucositis, and also in different pain conditions like brachial plexus neuropathy or trismus. So can you please explain about photobiomodulation therapy in treating these complications?
I don't use photobiomodulation but low level laser therapy. I don't know whether it is called as photobiomodulation. But yes, there are many papers. I have never used it, but we use cryotherapy also. Cryotherapy has a good role, especially for oral mucositis, but not for the plexus.
Okay, thank you.
And about the sucralfate cream for mucositis. Yes, you can use sucralfate cream. You can use honey. There are many things. But see, because of time constraint, I have not mentioned many things. I mentioned the important things which have certain evidence and which are practicable things. Yes, you can use sucralfate cream. You can use something called as. There are many type of medications, polypharmacy medications which are used. Okay, now they can mix sucralfate along with lignocaine. Okay, and you can just apply it over, or you can just drink sucralfate, because what happens is that it not only causes oral mucositis, it also affects your esophagus. It also affects your gastric epithelium. So it is not that it affects only your oral mucosa. So yes.
And we'll take this last question, and we will come back after the end of the session to take up more questions. Dr. Deepthi Paliwal is asking, can you please suggest few drugs for palliative care for cancer patients, especially the elder one and with oral cancers who cannot take oral or injectable forms?
Okay, so now here it is a challenge because they are not able to take oral as well as injectable forms. Then we have only available forms are the transdermal devices. So that's the what we call it as transdermal fentanyl patches or transdermal buprenorphine patches. That is what we can use. So those are the mode of therapies.
And
or else even subcutaneous we can still use.
Okay.
Injectables.
This last question: role of doxepin in mucositis.
I have not used, so I have no idea. I am sorry for that.
Okay. All right. Thanks, Dr. Raghu. We request you to stay with us till we complete and give your inputs.
Will be off. Is that okay?
Sorry.
My video will be off. Is that okay?
No, that's fine. That's fine. Thanks for being with us, and I'll come back to you.
Sure.
Yeah, we'll move on to the next speaker. Shruti, go ahead.
The next speaker is Dr. Carina Lee, who's going to speak about the role of POCUS versus other image modalities in musculoskeletal
Dr.
medicine.
Carina, are you there? Dr. Carina?
Yes, I'm here.
Oh, okay. Yeah, I welcome you. Yeah, go ahead.
Yes.
Just a minute, ma'am. She's the director of Hong Kong Pain Medicine Center. She's chairman for Hong Kong Society of Musculoskeletal Pain. She's the honorary assistant professor, Department of Anesthesia and Intensive Care, Chinese University of Hong Kong. She's the head of musculoskeletal US ultrasound module, master in geriatric and musculoskeletal medicine, CUHK. She's the Hong Kong Pain Foundation Council member, and she's on the board of Pain Medicine, Hong Kong College of Anesthesiologists. Over to you, ma'am. Hello, Dr. Carina.
Yes, I'm here.
Can you share your screen, Dr. Carina?
I'm trying to do so. Can you see it?
No, not yet.
Now?
Yeah, we got it.
Yes, okay. Good. So good evening, everyone. So I'm from Hong Kong. My discussion point is the role of point of care ultrasound, which is other image modality that we used to use as pain physicians. And I have some of the ultrasound image to share with you as some of the simple case series of patients having different kind of musculoskeletal pain. I have a private one-stop multidisciplinary holistic care medicine center, and so we usually assess patients from different modalities, and we also offer best care for the patient such that we want a one-stop service. So we would like to apply the point of care ultrasounds for the cancer patients. Because a lot of time they may have the recurrence, they may have bone metastasis, the vertebra, or they may have, the soft tissues like CA breast or metastasis to the ribs or wedge collapse, multiple myeloma, and there's certain sizes that actually common bone metastasis. A lot of time when they presented with back pain, we are not very sure whether they are really is related to the cancer-related therapy pain, just has been discussed with the radiotherapy. The patient may have fibrosis and some other musculoskeletal pain related to the therapy itself, or even the surgical interventions, biopsy, drainage, or post-surgical wound mastectomy, thoracotomy, or hernia repair, nephrectomy. There are certain surgeries we are known that have post-operative neuropathy pain. So when the patient presented with the pain, sometimes we are not very sure whether they are come from the recurrence or metastasis. So we allow one-stop service, and the patient have peace of mind, and then they don't have the hassles to go for a CT scan or even for soft tissue MRI, and also that is very expensive. And another good thing about the point of care ultrasound is that a lot of surgeons or gynecologists, head and neck surgeons, they all have that in the office. And maybe sometimes we share care in some hospitals, and it's very easy if you have a portable ultrasound, then they allow instant diagnosis. And at the same time, for us pain physicians, we can actually do diagnostic work and allow dynamic assessment for the patient as well. So as we all know, for cancer pain, then we have, mixed pain. We can have nociceptive, somatic muscle pain from the muscles, tendons, or fasciitis, versus as their own degenerative disease or other medical disease like gouty arthritis. Some of the malignancies like malignant multiple myeloma, or even related to some of the therapy, they may have gouty attack. So the ultrasound allows us to distinguish the nociceptive arthritis pain or acute pain and from some of the really bone or ribs metastasis pain. At the same time, we can have the dynamic assessment whether this is come from the muscles when the muscle contract or and movement, whether the pain is from the musculoskeletal. If the pain is not from the musculoskeletal, that means the pain can become from the visceral, like the CA pancreas or diaphragmatic pleural effusions and the refer pain, and that is usually very dull, again, difficult to locate. We don't want the patient every time whenever they have the pain, they need to have very expensive diagnostic radiology. For them, it's a lot of burden, repeated CT scan or MRI. According to the new diagnosis of classifications for chronic pain, as we know, International Association of Study of Pain have already showing that cancer-related and post-trauma nociceptive pain is two of the the most secondary pain we need to classify. On the other hand, a lot of our cancer patients, they also have mixed pain syndrome. As I said, it can be neuropathic, it can be visceral, it can be musculoskeletal. And that is very nicely reflected by the IASP new WHO classifications of pain. So we need to delineate whether this is primarily the pain from the cancer itself, or actually it can be related to the treatment. Radiotherapy, surgical trauma, or related to the metastasis, or primarily the patient's degenerative musculoskeletal pain. It's very important, as you can see with the anatomy diagram, that actually a lot of pain, we can have it, refer out from the sympathetic chain, which is the visceral, and like for the lung or the abdomen viscera, then the pain will be referred to the back. While we can also have some pain that related to the spinal compressions, as we have wedge fracture related to bone metastasis, or multiple myeloma, multiple ribs fracture, or the wedge fracture. And also some of the patient may have this central spinal canal metastasis. And a lot of times, sometimes the patient may also have pasopathy related to either the post-radiotherapy pasopathy, brachial passes, lumbar passes. And so it's very important for us, ultrasound, to see it, whether it is an acute inflammatory pain. There is a component of acute arthritis, fasciitis, soft tissue inflammations, post-radiotherapy edema, or actually it's the tumor related edema. We can see the tumor itself. Then we can decide, okay, the patient may need anti-inflammatory drug or even the steroid. And we know that there's nerve irritations, then we give the neuropathic neuromodulating medicines. And as need for visceral pain or other severe pain, then we can consider opioids. But having said that, if we can locate with the ultrasound, then we can do much more earlier pain intervention for cancer patients. As the new WHO guidelines, we always have early pain interventions for our patients. Professor Vincent Chan is my teacher back in 2005 while I training in University of Toronto for the Fellowship of Clinical Regional Anesthesia. He already said that, ultrasound is the future for quality pain service, and it is the standard. And after 15 years, it has been already proved that actually the ultrasound, especially the portable one, we can take it to the ward, to the clinic, and then we can see exactly the soft tissue. We can see very nicely the muscle fascia. We can see the ribs. We can see the pleural movement, and whether the patients have surgical scar or post-radiotherapy radiation soft tissue edema, then we can see it. And very important is that we can compare, the painful side to the non-painful side. And usually for tumor, as we all know, they should have multiple features. In the past, we rely on CT image with contrast. And a lot of our patients, they may be elderly patients, or they may have renal impairment, and they shouldn't, tolerate too high dose of contrast. And with the ultrasound, actually, we have able to have the immediate diagnosis at the point of care in the pain clinic or the center. Then we can turn on the color Doppler and then see it, the tumor, soft tissue tumor, and then see whether there's multiple features. At the same time, we can also see how's the nerve running, whether the nerve is being impinged or the brachial plexus is being infiltrated by the tumor, or whether it's the lymph node metastasis at the head and neck region, or cerebrus at the axillary lymph node region. And then we can account the whether it's related, whether it's the scar issues, entrapment of the nerve, or actually is the nerve being infiltrated. Usually being infiltrated is painless, as we all know. The tumor itself sometimes is not so painful itself. It's mainly the mediators release irritate to the nerve. So we can either see it with ultrasound, or we can do part of the localized pain. We can do local injections. Normally, we bought the nerve with hydro dissections near the nerve, and for any adherence after the radiotherapy, fibrosis stuck to the nerve, or post-surgical scar lymphoma. Well, we can see the fibrosis, and then we can inject, and then to see the hydro dissections and the local. And actually, a lot of time radiologists, before they do the biopsy, they also do the hydro dissections using saline or local anesthetic to isolate the tumor or the lesions from the surrounding area before they do the biopsy and the FNA. Well, very nicely is that with the ultrasound, we can distinguish from the acute, gouty arthritis, hyperemia, with the tendon type of increase in Doppler signal from the tumor. Tumor recurrence is totally different. A lot of time, because the PET CT cannot give us the information about the joint and the limbs, upper limbs, lower limbs, because usually the PET CT is sparing the limbs, sparing the humeral head, sparing a lot of time, the femur and the fibular head. So that is some of the common sites that may have, also the tumor metastasis. So it's very important that whenever they arise, have some of the musculoskeletal pain in the joint, and then we can actually scan it, whether it's a hot lesions with tendonitis, inflammations, and then we can see whether it's a rim of edema, or we can see anything like lymph node or abnormal soft tissue mass around the area of pain. So the implications for the ultrasound is that normally, what is the pain management for metastasis or the musculoskeletal cancer pain? So we have conservative, we have, oral medicines or systemic drugs, and in some terminal palliative patients, we may have intravenous desensitization, Novocaine, infusions of ketamine, and other, non-interventional with clinical psychologists, counseling, spiritual care, or exercise therapy. Well, for interventions, then we can consider, if it is a metastasis, then or a chance of lymph node or tumor infiltrations edema, then we don't do dry needling, we don't do acupuncture or other electrotherapy by the physiotherapy. So this is the important part, isn't it? A lot of time, head and neck tumor, head and neck surgeries, and then nasopharyngeal cancer, they have radiotherapy over the leg and shoulder region. And afterwards, they have pain. A lot of time, patients themselves will just go to the physiotherapy themselves. But if that is a tumor recurrence, that will spread the tumor. So part of care ultrasound is that we immediately to assess for the patient whether it's fibrosis or whether it's related to tumor, any lymph node, and then we can stop the patients from keying on some of the palliative or the traditional or allied health too tedious multiple therapy. So we can have arrange them earlier pain intervention. So we can do nerve root block. We can consider if it's the radiotherapy fibrosis. We can see the scarring in the muscles and then we can earlier botulism toxin injections, or we can do local anesthetic plus steroid hydrolysis or adhesions from the nerve. And also other neuroablative alcohol neurolysis block, or combine it with the radio frequency ablations of nerve and the tumor, like with metastasis, or even we can do it with the radiologist or radiotherapy oncologist to plan for the pain management. So the ultrasound can allow seeing, the muscles. We can see the deep fractures and the superficial fracture. We can see the fibrosis and the fibrotic scar. You can see this is like a fibrotic fracture, and then how it relations to the subcutaneous tissue. Sometimes immediately after the radiotherapy, we can see the subcutaneous tissue, the dermis, deep layers with the superficial layer will be very edematous or maybe fasciitis with the Doppler signal, and we can explain to the patients. We can have tropical onset and then encourage the patient for early movement and mobilizations. And we can see the pleura, we can see the ribs, and if there's a rib metastasis, we can see the tumor. So this is to show you post-radiotherapy, the patients can have very thickened fracture, and you can hardly see any muscles there. And this is the pleura. So how we can do that? We can do ultrasound real-time guidance for the injections and hydrolysis of adhesions, and then you can later on see layers of the fascia. We can use the ultrasound guide to dissect different layers, the deep fracture, the superficial fracture, and then allow the patient to move, and they are very happy, to immediately see the improvement afterwards and improve the range of movement immediately after the block in a single clinic consultations. And well, for some of the joint, like shoulder joint pain, then we can see the patients whether because of post-radiotherapy, they have pain, they have fear avoidance, they don't move their arm, and then they have the disease side. You can see the disease side, there will be a decreased bulk of the muscles. The depth, like this, on the right side, you can see the depth of measurement, like this is 4 centimeters. And then we can compare the trapezius muscles and then the supraspinatus muscles, rhomboidal muscle, and then we can even see the pleura on the electro side is different. And sometimes we can also see if in CA lung patients with recurrence of the pleural effusion, we can see the pleura is not moving, and then we can go to the base of the lung to see any pleural effusions, and then explain to the patients where their pain exactly come from. So it can be from superficial, the post-radiotherapy, fibrosis, fasciitis, atrophic muscles. It can also related to deep pleural adhesions, like CA lung, post-radiotherapy, or pleural disease after repeated pleural drainage, and then they have pleural disease, and this can be the pleural referred pain. So ultrasound help us a lot. It's not only used in orthopedic or rheumatologies, and I will introduce to you all, palliative oncologist physicians or oncologist people, and even some other people having use point of care ultrasound. Try to get the ultrasound, and then you scan to your patients, and some more higher sophisticated machine nowadays can allow to measure tensile myopathy or sonoelastography, and this helped a lot for those post-radiotherapy neck, head and neck pain, myofascial or back myofascial pain. And this is to show you, this is more sophisticated machine, and usually in research unit or big academic hospital, or rehabilitation science people, they would have this, and then this is very good. And in Hong Kong, we have the University of Polytechnic, the biomechanical engineer. They have intense interest in this and they support a lot of researchers, and like nasopharyngeal carcinoma, post-radiotherapy patients, they have studies showing that after the radiotherapy, the soft tissue is more stiffer. And then maybe thickened fascia, and notice with the ultrasound we can see the fibrotic scar. So this is to show you relatively young lady, 42 years old lady with the carcinoma of breast 3 years ago, and then she have underwent neoadjuvant simple mastectomy and then neoadjuvant radiotherapy, and she was found to have the local recurrence. Unluckily, in March, and then she has the biopsy done over the local breast anterior chest near the previous mastectomy scar, and proven that this is a recurrence. And this is to show you the pain diagram that she have very severe right shoulder and arm pain, and then she have the pain, severe burning pain, shooting pain, and you can see this is the pain, ID pain with the score of 4, touching pain, electric shock, light burning, and pins and needle over the whole right arm, because I suppose that has the vacuole plexus involvement. And I used the HAS assessment, the hospital anxiety and depression scales, so a very high depression score and anxiety scoring. She come to me after 1 month of trying to go to the traditional Chinese medicine for herbal treatment. So immediately, I think I need to use the point of care ultrasound to assess on her. Although I know that I may not able to detect the lymph nodes, but I know, we all use a centennial lymph node or lymph node diagnostic workup at the axillary regions to see the lymph node at the axilla and head and neck region. And for her case, I also would like to see whether I can spare her from, vacuole plexus or neck and shoulder combined MRI of the soft tissues involving knowing where exactly her pain impingement by the tumor. Because at that time it's still very early, her PET CT is just show up a tiny area around the local recurrent site have the signal. We all know, there are certain limitations to the PET CT. And with more detailed image, it would take her a lot of money to have the MRI contrast, and so she preferred to have the to have palliative care by the traditional Chinese medicine or herbal medicine, and avoid the Western medicine traditional way, because in the past you have not enough good counseling in a center of a very busy public setting. So I explained to her that it can be, the vacuole plexus impingement at the either, from the leg interscaling regions, or it can be anterior pectoralis minor subclavicular region, and also axilla. So I explained to her that this can be either, it can be sympathetic maintained pain because you have the finger edema, and also it can be lymphoedema. So I convinced her that she see the ultrasound herself, and then not to go just for the traditional Chinese medicine chemotherapy, you know, the herbal chemotherapy, she think. And I told her she could, as because she's so young and it's only the first time she have the recurrence, she should go back to a conventional therapy. So I showed to her the ultrasound that she didn't have any bone metastasis. The humeral bone contour is very nice. And I showed her, you know, the foregut, the carotid artery, the nerve with C5, 6, 7, the brachial passage is very nice. It's clear of tumor. Subclavian level, the first rib, all clear of tumor. Only the tiny point below the infraclavicular area, the second part of axillary artery, I can see increased vascular signal. I can exactly locate where the tumor soft tissues and it intermingle with the axillary trunk and with the edema and some of the lymph node. But good thing is that the pleura is clear, and see the pleura movement is nice. The ribs is clear, and so I convinced her that, as you can see, the tumor metastasis herself vividly, and she know that it's not the bone erosions. So she is very happy to go back to find oncologists, medical oncologists, and I give her some of the oral medicine to help her with the pain. I give her back the confidence to see oncologists, and then plus or minus, if she think later after stimulation of the tumor, she may have the surgeons to help with some of the chest wall local recurrence, because she doesn't have any other lung or bone metastasis yet. So I'm very happy that actually she sent me back a thank you letter 1 month afterwards, that with the trust and the faith, we start the chemotherapy, and her pain and the upper limb movement is much more improved. So this is the good thing about the ultrasound, allow us to have instant point of care diagnosis. And it serves the purpose. Diagnosis means a lot to cancer patients. If it is not metastasis, they are very happy. They know that it's just the chemotherapy-related secondary pain, musculoskeletal or degenerative pain. If even it is a metastasis, they know that there is a solution at the point of care, and she can see the ribs metastasis, she can see the nerve infiltrations, and then they can decide themselves, and we can formulate a better plan for them. And for pain physicians, we can discuss with them, okay, what kind of injections, whether it's acute therapy, or we will go for, you know, if it is actually is not a recurrence, it's just post-radiotherapy chronic spasm, we can consider botulism toxins or just local anesthetic trigger point injections to relax the muscles, and then send them off for rehabilitation exercise. Or we can think of as a tumor, then we can discuss with the interventional radiologist. It is possible that we can do the radio frequency ablation of the tumor at the same time we ablate with the radio frequency nearby the nerve. We combine procedures. In the past, we used fluoroscopic approach for different kind of nerve root or CT guide, and it is more expensive. And now, like this, we can have a cervical level, we can see the nerve root nicely, soft tissue tumor, we can see it, we can use ultrasound needle real-time guidance, and we can see any edema around the muscles. And even for a lot of cancer patients, they may have post-herpetic neuralgia, they may have neuritis. So we can see with ultrasound the scarring, and then we can also at the same time to see whether it's only solely the Tringles issues, or the patient have local recurrence at the ribs by delineate different muscles tissue pain. And ultrasound can help, some of the patients for missing the cancer diagnosis. I have some patients have been first seen by orthopedic surgeons, and then they refer to psychiatry because of poor sleep, very severe pain, and then come back. Psychiatrists refer to me, and then they just concentrate on the spine, MRI and CT abdomen. What they miss is it can be a lung, so they miss out the CT forest, and then I diagnose it, and it is a metastasis, and so I send him off for oncologist. At the same time, I do a neurolytic intercostal nerve block with the alcohol for him. Okay, so ultrasound, we can see the ribs very nicely. We can see the pleural intercostal muscles. And for deeper paravertebral, we can now, a lot of people now actually do erector spinal fascia pain block, or we can do for a paravertebral block if it is solely a musculoskeletal issues. And we can see if there's a cancer cases, we can decide whether we do radio frequency ablations, discuss with the patient at the same time. And for musculoskeletal issues or postoperative neuralgia, we may consider for the pulse radio frequency ablation of the dorsal wood ganglion for the patients. And I'm not getting detailed discussion about the choice of radio frequency. So this is to show you some more image because of the time limit, I cannot show you all the image from head to toe. For some of the patients, they may have, ipsilateral, like the back pain, we can see the thoracic lumborum muscles, we can see the spine. For the spine, we can see the nerve root. Commonly, sometimes the patient have bone metastasis. We may see the soft tissue tumor around the psoas compartment. And so we can see whether we can see the nerve root, we can see the tumor infiltrations around the area. And this is to show you some of the pathological fracture. Normally, for spine, we can see very nicely the spinal process, laminar, facet joint, the different bone planes. Well, for the pathological weft fracture, we can see those patients, they know that spinous process, laminar pain, totally. And then we can see lesions. We can see how those lesions, and then the artery. So for this can consider, combined with interventional radiologists, whether the patient radio frequency ablations at the same time. So this needs multidisciplinary discussions with orthopedic surgeons and oncologists and interventional radiologists, and we discuss that as a team together. And well, for some other patients, even now.
Sorry to disturb you right now, but we're running on a tight schedule. Just wanted to let you know that you have 2 more minutes.
Yes, okay, thank you. So we can see the fibrotic scar, even the patient has laminectomy and stuck to the nerve root. This is to show you the normal what we can see with the spinal ultrasound. Spinal process, laminar facet joint, and then we can see the transverse process and also the muscles. And so ultrasound can guide us as pain physicians. We can see different level of the spine, the facet, the muscles, and then so we can decide whether the patient is really have just because of chronic immobility, disuse syndrome, they have the degenerative spine pain, and we can see very nicely the normal bone contour, or actually they have metastasis. So if for the normal other degenerative pain, we just treat as normally, okay? Well, it is a tumor, we do combine radio frequency ablations and neurolysis. So a lot of time, we know that we also have patients have gone pain, and then maybe, the lymph node, gone lymph node. We can also use the ultrasound to detect the lymph node, any increased vascularity, or because it is just solely a post-surgical wound, muscles impingement, or fibrotic scar tissues. This is to show you this is a laparotomy fibrotic scar tissues, and there's no tumor. I have a lot of times surgeons refer to me to ensure or reassure the patients. So a lot of time cancer patients, they need a lot of reassurance. So if it is a scarring enchanted nerve, we just do a hydrolysis of adhesions to feel the enchanted ilioinguinal nerve or just have a tap block. And then part of care ultrasound allow us to scan on pelvic organs as well. Can see the bladder, we can see the uterus as just the normal surgeons do. And at the end, I would like to discuss about, the pelvic tumor. Okay, sometimes patients, they may worry about whether they have the pelvic recurrence or pelvic metastasis. And it can be sometimes it just have fracture, at the same time. So ultrasound also allow point of care to delineate superficial tissues, the sacrum fractures. We can see the sacrum nicely. We can see the sacral canal. If it is metastasis, we can detect the tumor there. We can consider ganglion implant bulk. If it is a iliac ring metastasis combined, and then we can consider, sacral nerve root bulk or sacral tumor, neurolytic or radio frequency ablations. Because of the time limitations, I can show you this is all the ultrasound we can use for our patients. So I would let you know at the end, even though it can be, the fibula had metastasis, we can detect with ultrasound to see the soft tissues and the tumor, and then we can do the radio frequency ablation. So holistic care for the cancer or terminal care. We always have to remember the patients want us to reassure them, to alleviate the anxiety. Point of care ultrasound allow us to empower the patients. If it is cancer recurrence, to face it, to see the tumor, you need the definitive care. Follow the oncologist, radiation oncologist, or the surgeon advice for definitive surgery. If it is just non-cancer, treatment-related pain, then we help them to have rehabilitation exercise, pain interventions, and this is the end of my presentations. And I hope that you can have more idea about how we can deal with real-time ultrasound. This is to show you one of these ladies. My patient is already 103 years old in Hong Kong. In Hong Kong, we have the longest longevity in the world. So I wish you all enjoy good health and your patient as well. Thank you very much.
That's really a wonderful talk, Dr. Carina, really. And it's a treat to watch your ultrasound pictures, and I had a good time with you in Tignis. I remember seeing all your ultrasound pictures. It's again a second chance for me to see your ultrasound images. And we know the musculoskeletal pain in cancer is a big area and it's an upcoming area. Thanks for enlightening us. We'll keep all the questions in the end except for one, Dr. Srinivas Chiluguri, who is our webinar series in charge, the senior consultant radiation oncology. He has a question. So we'll take his question and rest of the questions we'll keep it in the end.
Yes.
Dr. Carina, it was a fascinating presentation. Thank you for exemplifying the role of ultrasound in both diagnostic as well as therapeutic interventions for pain management, especially in post-chemo radiotherapy setting. I mean, I wanted, in my experience, among other tumors, I treat sarcomas as well. And when you treat intact sarcomas, especially in the paraspinal location, the nerve entrapment, the plexopathy is a real trouble. And once the pain sets in, it's very, very challenging to treat and to deal with those kind of pain. So I was thinking, do you see a case for a referral to a specialist like yourself before we start the radiation? Because especially we know that these are the patients who are likely to have some nerve-related issues because of radiation therapy. And you could do some prophylactic intervention or have a lower threshold to intervene when they start to have pain, so that they don't have the full spectrum of full blown out pain syndrome, and then we attempt to control them.
Yes, thank you for your questions. Actually, for pasopathy, like the upper limb or the lower limb pasopathy, brachial passes and the lumbar passes. First, we need to discuss with the patients, because if we do the block, if it is a neurolytic, that will be affect the movement of the limb. So exactly for the young lady have the brachial passes impingement. For her, I discussed with her. She initially prefer to give up chemotherapy or any definitive surgery, or they should give up on treatment, active treatment. She thinks she is going to die with the recurrence. So I will explain to her I can do the definitive neurolytic block or radiofrequency ablation locally, but it will traumatize the somatic nerve. So we'll have the limb weakness afterwards. So it's always a balance with benefit. So that's why I say always we need a multidisciplinary team. In Hong Kong, we have a lot of public hospital or some of the major hospital. We have tumor board. We have pain oncology pain clinic. We can see the patient together, or we can just for me, like private practice, I discuss with surgeons. I discuss with oncologists to formulate a plan for her. So if it is not a case for further chemotherapy, radiotherapy, or surgeries, then I will discuss with patients. Okay, if it's just for palliative, then we may possibly either implant a regional catheter for her, or just a local anesthetic or steroid to shrink the tumor, decrease the tumor irritations to the nearby nerve, and then to cover with some oral analgesics, and to go for more definitive therapy, like you said, radiotherapy. As we all know, sometimes with titrations of oral medicine, opioid, steroids, or some other means, we can allow the patient have a period of less pain period to undergo the interventions. So we try to decrease the patient's stay in the hospital. That's what usually most of the cancer patients prefer. So there's a lot of discussions, but nowadays, because we have some of the ambulatory local anesthetic regional pump, so it also I have the either intravenous patient controlled morphine, or you can have oxycontin. So I think this is all the possible solutions for patients have similar problem.
Thanks, Dr. Carina. It's really wonderful. Thanks for enlightening us. So I really apologize for the speaker and the delegates that we are behind the schedule. So let's move on to the next speaker. And Dr. Carina, please stay with us.
Yes.
Yeah. Shruti, please go ahead.
The next speaker for the session is Dr. Ram Pasupuleti. He will be speaking on medical management of cancer pain. He is currently the Director, Center for Pain Management, Bowling Green, Kentucky, USA. He is the past President, Kentucky Society of Interventional Pain Physicians. He underwent fellowship training in pain management under world-renowned pain physicians Dr. Prithviraj and Dr. Gabor Rax. Faculty, American Society of Interventional Pain of Physicians, conducted several pain management workshops across the world, USA, India, Indonesia. Co-author of ASF Guidelines for Safe Opioid Prescribing and Facet Joint Interventions, conducted the first cadaver course in pain management in India in 2006, first spinal cord stimulator trial for pain in India. Over to you, sir.
But last but not the least, he is my teacher as well. I got my training done from Dr. Ram Pasupuleti.
Even me also. This is Dr. Uma Sridevi. I am very happy to see Dr. Pasupuleti sir after the break. I am very, very happy. Welcome you, sir. Thank you so much.
Good seeing all of you guys. Very, very nice. Been far away, I'm sitting here in the United States, and good to see all your faces. So let's get started. I'll start the screen sharing. All right, can everybody see my screen? Yes?
Yeah, we can see you.
Yes, we can.
All right, guys. Okay, let's go. So we are about 55 minutes behind the schedule. I'll try to keep to my time. extensive introduction for me, so I don't need to go into all of that. I'll have to say this is a disclaimer, no outside funding, grants or industrial support for this presentation, no conflicts of interest. I use information from WHO publications, PubMed, and from various oncology groups. Now, I've structured this talk in the setting of guidelines. So the objective of this talk is to provide a framework of evidence-based guidelines and recommendations for the best practices in medication management of cancer pain. In doing so, to enable patients and providers involved in cancer care to understand and apply the guidelines in a practical setting. So it's like Indian philosophy, we don't talk anything that is not practically useful. So that is the reason why it has to be useful for everybody. The structure of the presentation will be, we'll start with introduction, and then I'll briefly touch on the guidelines that are available for the medication management of cancer pain. And then I will kind of hone down mainly onto the WHO guidelines. And I'll tell you why I picked the WHO guidelines, because one, they're universal, two, they're simple, three, they're practical. So universal, meaning that they can be applied anywhere in the world. Here in Bowling Green, Kentucky, I can apply those guidelines. And there, Dr. Raghu Thota sitting at the Tata Memorial Hospital can apply these guidelines, and I'm sure he does. Dr. Anand sitting at the Apollo Proton Cancer Centre can apply these guidelines. That makes them universal. Then simple, because they are simplicity itself, and practical. So that is the reason why I chose WHO, and we'll come to the Indian guidelines as well, and I'll talk about them here. We'll talk about the chronology of how WHO started their guidelines, and then the guiding principles that they use for these guidelines in 2018, and the recommendations that they make, and then we finish with the summary. So again, the statistics, I'm just going to breeze through. 18.1 million new cases in 2018 of cancer, 9.6 deaths. So the cancer is one of the leading causes of morbidity and mortality. And 55% of patients undergoing anti-cancer treatment experience pain. 66% of patients who have advanced cancer have pain, and 80% of people dying from cancer experience pain that lasts for about 90 days. So cancer pain is a major cause of unnecessary suffering. And here I have to bring in a personal note. A friend of mine, a classmate of mine, Verghese Jacob, died yesterday from lung cancer. So I'm going to dedicate this talk of mine to his memory. May his soul rest in peace. That makes it more personal for me. I've always been interested in cancer pain. So cancer pain therapy, the mainstay is pharmacological interventions, which is what I'm going to talk about. But as we know, radiotherapeutic, anesthetic, neurosurgical, psychological, physiotherapeutic, spiritual, and social interventions play essential roles. So this is a team effort. It's not just one. Guidelines are available from different countries, different organizations. I'm not going to go through every single thing. You can read it, WHO guidelines, and I've given you the links. You can click on them. WHO, NCCN guidelines from USA, and then European Society for Medical Oncology, and then Polish guidelines. And then coming to Indian guidelines, the first one, as you can see, was done by the Indian Society for Study of Pain with Dr. Raghu and Dr. Bhatnagar. Please take a moment to appreciate and applaud their efforts. Excellent effort. I read this article. They give the guidelines in the setting of Indian cancer pain management. And of course, like most of the guidelines, they do follow the WHO guidelines, which brings me back. That's the reason why I've used the WHO guidelines. Now, the chronology of WHO guidelines, how did this come to happen? In 1986, they gave us the wonderful 3-step pain ladder. I don't have to expand on that. It is wonderful. Everywhere it's been adopted, and we use it even today. And then 1996, they gave us another unique, distinctive, and excellent concept of use of analgesics by mouth, by the clock, by the ladder, for the individual, and with attention to detail. We'll come to that in the guidelines one more time. And eventually, in 2018, they gave us the most recent guidelines. The process started in 2016. They did the typical thing that we do. They recruited a group of experts from all over the world. They called them the Guideline Development Group. And then they sat, they identified, appraised, and synthesized all available evidence, and then they formulated recommendations. And that's what we want to talk about. And depending on the evidence, they said we give this recommendation, and when the evidence was not enough, but they saw a practice was doing okay, one single thing was doing okay, they said we'll give you a best practice statement for that. And then sometimes they say we do not recommend either for or against a particular practice. That's how the guidelines are set. That's how we're going to talk about that. And so again, the guiding principles, I'm not going to go through for lack of time. I'll stress on the most important guiding principles. Number 2, global assessment of the person should guide treatment, recognizing that individuals experience and express pain differently. That is, I felt, the single most important guideline that has to be followed. So you have to assess the person as such, not the cancer, but the person. Yes, cancer is important, but treat the patient, not the cancer. And then the treatment should be guided, recognizing that individuals experience and express pain differently. So, simple thing for a neuropathic pain, you treat it a little differently from somatic visceral pain. So, assess the individual, assess their pain, and then treat them. And now, coming to the next most important guiding principle that I would consider is administration of analgesic medicine should be given by mouth. Oral route is the preferred one, by the clock. So the dosing should be appropriate. So by the time one dose goes away, then you dose the other one. Don't wait. So by the clock for the individual, once again, treat the patient and treat what kind of cancer he has, what kind of pain he has. And with attention to detail, a good example is dose the first dose of medication, give the first dose of medication when the patient wakes up, and then give the last dose of medication when the patient goes to bed. So simple things like that. So cancer pain management should be integrated as a part of the cancer care. From the word go, it should be integrated. And this brings me back to my friend, Verghese Jacob, who died yesterday. His cancer pain cancer care treatment was given initially, but pain management was not a part of his cancer care. So he had to come much later to me for his pain. So it behooves all of us to put pain management as an integral part of the cancer care continuum. Now, coming to the recommendations. So they divided the recommendations into 3 categories. The first category is the analgesia of cancer pain. So they talk about how do you start treating cancer pain? How do you maintain treating cancer pain? And what about breakthrough pain? What about when to stop the opioids and so on and so forth? So how to start initiation of pain relief. So NSAIDs, paracetamol, and opioids should be used at the stage of initiation of pain management, either alone or in combination, depending on clinical assessment and pain severity in order to achieve rapid, effective, and safe pain control. The bottom line in this recommendation, it's a strong recommendation, low quality evidence, but it's a strong recommendation. They say that pain should be assessed and treated accordingly, according to the intensity of the pain. So you don't treat moderate pain with mild analgesics, as simple as that. So what I'm going to do is I'll go with the recommendation of the WHO, and I'll tell you what I do in my practice as well. Now, for example, in my practice, patients usually don't come to me at the beginning. I'm a pain management physician, so they come while they're being treated and they're already on pain medication. But do I use NSAIDs? Of course I do. Yes, I add them if there is an inflammatory component for the pain. Do I use paracetamol? Yes, I do. If for some reason the patient cannot take NSAIDs, then we use paracetamol as, in addition to opioids. If they're in moderate pain, even the WHO says don't start with mild analgesics. So they alter their ladder a little bit and say, okay, so you still follow the ladder, but they say when there is moderate pain, don't start with mild analgesics. That is the point of this recommendation. Now, coming to maintenance, how do you maintain? And this is a good one. And the favorite question is, what opioid should be used? The bottom line that WHO says is any opioid may be considered for maintenance of pain relief, alone or in combination with NSAIDs, depending on the clinical assessment and pain severity in order to achieve sustained, effective, and safe pain control. So any opioid is okay. And the point being, because different countries have different rules and different regulations, and some opioids are available in some countries, others they are not. Good example, I have the luxury of having almost everything: hydrocodone, oxycodone, hydromorphone, morphine, fentanyl, buprenorphine, and I may be forgetting a couple. So India doesn't have as many, but it doesn't matter. You use what you have in your country. That is the point of this. I think WHO compared four studies, four opioids: fentanyl, morphine, oxycodone, and buprenorphine. That's what they compared, and they said there is no best opioid. So the correct dose of opioid is the dose that relieves the patient's pain to an acceptable level. Patient responses to opioid medicines vary by patient and vary by medicine. Again, they come back to the cardinal rule: treat the patient's pain according to its intensity, severity, nature, and so treat it individually. And then evidence indicates that a combination of high-potency opioid combined with an NSAID is better than the alternative analgesics. And the choice of opioid analgesic doesn't make much difference either in speed of relief, duration of maintenance, or pain reduction, or functional outcome. So there is no single best opioid. Now, treatment of breakthrough pain, they did not find enough evidence to make a recommendation. So they said a best practice statement, breakthrough pain should be treated with a rescue medicine, which should be an opioid such as morphine in its immediate release formulation. So what do I do in my practice? Absolutely same thing. So breakthrough pain is treated with an immediate release medication, not a sustained acting medication. Choose whatever is available in your country. Morphine is excellent, MSIR, immediate release. And fentanyl is available in a lot of countries. I know India it's available as well. The transmucosal, Actic. But the cost is prohibitive. That is the reason why WHO says just stick with morphine, which is a cheaper medicine, and it's available universally. Switching or rotating opioid medicines. In the absence of evidence, WHO makes no recommendation for or against the practice of opioid switching or rotation. So they say there is not enough evidence to say yes or no to opioid rotation. What do I do in my practice? Absolutely, I do rotation of opioids. A good example is my friend Verghese Jacob. We started him off on tramadol initially, and as the disease progressed and he probably built a tolerance, we switched him over to buprenorphine. Buprenorphine did not help much. Then we switched him over to morphine. So yes, I do opioid rotation, and that's what they say. The absence of evidence is not evidence of absence, right? So absence of evidence is not absence of efficacy. So if it's a practice that you have found useful, continue using it. Then choosing between immediate release morphine and slow release morphine. So what they say is regularly dosed immediate release oral morphine or regularly dosed slow release morphine should be used to maintain effective and safe pain relief whenever oral dosing is possible. So with either formulation, immediate release oral morphine should be used as a rescue medicine. So rescue medicine is always short acting, right? You don't use long-acting medicines for rescue medication. So it's a strong recommendation, moderate quality evidence. So what they say is immediate release morphine should be available. Sustained release morphine is great if it's available, but they prefer MSIR. What do I do in my practice? Absolutely. I use immediate release morphine or short-acting medications as my first go-to. And if I feel that they're stable on that dose, then we can think about converting them to the sustained release, but the mainstay is still the immediate release morphine, just like the WHO guidelines. Coming to route of administration, no question, hands down, oral route of administration is the preferable route. And they talk about two other routes. When oral is not possible, transdermal. When you have fentanyl, you have buprenorphine, you can use. And then if these three are not possible, then you go to subcutaneous route. So they say subcutaneous route is preferred over intramuscular injection because it is easily done and it's less painful. Cessation of opioids. In cancer pain, stopping opioids usually is not a thing, but sometimes, you do a nerve block or a neuroablative procedure, the pain goes down, then you can always talk about cutting back on the opioids some. So the point they're trying to make is reduce the opioids, don't take them off completely, reduce the opioids to avoid withdrawal symptoms. Now coming to the second focus area, we are done with the analgesia for cancer pain. The second focus area is the adjuvant medications for cancer pain. What other medicines you use in addition to the opioids? So steroids are the most commonly used adjuvant medications. Adjuvant steroids may be given to achieve pain control when indicated. is a strong recommendation, moderate quality evidence. What do I do in my practice? Yes, I use steroids, quite a bit of steroids actually, for most kind of pains. Then antidepressants, they talk about TCAs, tricyclic antidepressants, SSNRIs are commonly used. They do not make a recommendation for or against antidepressants. Do I use them in my practice? Yes, I do. Duloxetine, Cymbalta, like Dr. Raghu mentioned, is what I use in addition to the opioids. Don't use much of amitriptyline stuff. But duloxetine I do use. And anticonvulsants, WHO makes no recommendation for or against the use of antiepileptics, gabapentin, pregabalin, and carbamazepine and valproate. What do I do in my practice? Gabapentin, I do use gabapentin for neuropathic pain. Pregabalin, yes, I do. I do not use much of carbamazepine or valproate. Coming to the management of pain related to bone metastasis, bisphosphonates are used quite a bit in this country. Do I use them? Well, the patients usually come on bisphosphonates to me. So I don't add them, but they are already on the pamidronate. And this is very specific for bone metastasis. And monoclonal antibodies, I think we are doing a phase 3 trial of tanazumab. I don't see much of that in the United States. Radiotherapy WHO makes a very, very strong recommendation, high quality evidence. I think this is the only recommendation which is strong with high quality evidence. So pain related to bone metastasis, single dose radiotherapy should be used when radiotherapy is indicated and available. In summary, the goal of cancer pain management is to relieve pain to a level that allows for an acceptable quality of life. The WHO guidelines are intended to provide evidence-based guidance to healthcare providers on appropriate approaches to initiating and managing cancer pain. So the guidelines can act as the basis for national guidelines, and I know for a fact the ISSP guidelines are based on the WHO guidelines. So I really appreciate that. Dr. Raghu can vouch for that. And for the inclusion of cancer pain management and care in primary health care programs. So WHO is talking about including cancer pain in primary care programs, not only in tertiary care centers like Tata Memorial or Apollo. No, we should talk about integrating cancer pain in the primary care setting, which is what Dr. Bhatnagar also talked about, using a person-centered and integrated approach. Thank you very much. That ends my presentation.
Thank you, Dr. Ram, for your excellent presentation on the pharmacotherapy. I think it's a very comprehensive one, and that covered all aspects of the pain in cancer. And I would like to take the questions towards the end of the session. I still one more speaker to go. I'm going to talk on interventions. And
okay, Anand, Anand, I have to leave, so I will ask you to take my questions. I trust Anand. He's my student, so he'll probably be a good person. And there's Dr. Joshi, of course, the eternal knowledge for pain management, and then Dr. Raghu is there. He's written the guidelines, so I'm sure they can answer your questions. Thanks, guys. Thanks for inviting me.
I'm sorry about your friend, Dr. Ram.
Yeah, it is. It's very personal to me, and I just lost him yesterday. And Dr. Sridevi was trying to help him as well in India. I know I was trying to coordinate it from here. It's difficult. So, but anyway, thank you.
Yeah, see you.
All right, bye.
Okay, go ahead.
Our next speaker, our final speaker for this session is Dr. Anand Murugesan, who will be speaking on interventional pain management for cancer pain. He's the head of the Department of Anesthesia, Pain and Palliative Care at Apollo Proton Cancer Centre, Chennai. He's a Fellow of Interventional Pain Practice, FIPP, and Certified Interventional Pain Sonologist at King's College, London. He is also a faculty in the London Pain Forum. Over to you, sir.
Hello, hi. Thanks, Shruti, for the introduction. Can you hear me? Can everyone hear me? Okay. So next. Okay, this is the hospital where I'm working. I'm Dr. Anand Murugesan, working as an interventional pain specialist and onco-anesthetist in Apollo Proton Cancer Centre. Yeah. So I always believe on this 5 W's and 1 H, one of the simple and an outstanding method to better understand and delineate any situation. So much so for the interventional pain management also. So what is interventional pain management? It is a definition given by the American Society of Interventional Pain Practice as a discipline of pain medicine devoted to the diagnosis and treatment of pain-related disorder, which also sets a goal to improve the patient's overall quality of life through minimally invasive techniques specifically designed to diagnose and treat painful conditions. Of late, this has taken a center stage in the management of a cancer pain, and it's a part of the multidimensional and multidisciplinary approach in managing cancer pain. So a point to be stressed here, it's multimodal. So the intervention alone cannot do any magic. So it's multidisciplinary, multimodal. The pharmacotherapy, the non-pharmacological methods like physical therapy, psychological therapy will complement the pharmacotherapies and your intervention. So it's the multimodal approach that is very pivotal. So the what is more important? No single method, no single strategy is important. It's single weapon is important. More than the weapon, the strategy is more important. So why we need to the intervention in cancer? Because it's targeted, it is precise, and it optimizes the medication. Because it specifically targets a nerve that carries the pain signal to the brain. It supplies the tumor area. You target and you block it or you ablate it. So you block the pain signals traveling down the pain fibers to the brain, and it is more precise and then gives a superior analgesic analgesia, and which is also an opioid sparing, as we are all very well aware about the adverse effects of the opioids. And there is a nice guideline set by Dr. Lakshmiya Manchkanti, has got a big series about the evidence-based approach to it. So every intervention what we do in interventional, in cancer pain, has got an evidence like non-cancer pain. So like it is because it is evidence-based and more target and precise, and has got a major advantage of opioid sparing and optimizes the pain medications. Like interventions are gaining more importance in cancer pain as well. So when to start? Earliest. Why early? How early? Today, right away. Because we never know. Hemodynamically stable patients can become unstable. All these neurolytic blocks, the interventions what we perform in cancer pain may not be possible if the patients are unstable. And you start a patient on any medication, as Dr. Ram discussed in detail about these medications, about their side effects and about their the pharmacodynamic profiles, and like it will have some effect on the patient's mentation and some adverse side effects because of the medications. Eventually patient, as there are studies like where the patient bond between the patient and the physician gets distracted. So they prove that you give an early pain relief and effective pain relief will improve the patient faith towards the pain physician as well. And of course, it improves the quality of life, because as I mentioned, optimal medical or to optimize the medical management, it improves your sleep, diet, as well as your mobility. And Dr. Sushma Bhatnagar madam has published an article on this about the individualized interventional pain management technique in early stage of cancer pain, which highlights all this the importance. And who are all the pain physicians? It is usually the anesthesiologist, but the radiation or interventional radiologist, the physical medicine rehabilitations, the neurosurgeons, and sometimes orthopedic surgeons also join the group of pain physicians to treat the cancer pain. And where to do? We can the neurolytic procedures, the neuromodulating procedures, the somatic blocks, they are all has got some effect on the hemodynamics of the patient. So I personally suggest to do it in a, need not be a tertiary care, but a settings where there is an optimal monitoring of the patient is available, and it's better to proceed with those cancer pain interventions. And these are all the equipments generally we need, so that again insist a point of having an institutional backup for doing all these interventions. So what are all the interventional types available for treating the cancer? Generally it is into 4, like a lot of my previous speakers have mentioned about the somatic blocks. Yes, we can ablate an individual nerve called somatic nerve block, and we can do a ganglion neurolysis. Dr. Muralidhar Joshi insisted upon the visceral pain, where like sympathetic blocks plays a vital role in dealing with the visceral pain, and your neuraxial blocks and catheters in terminally ill patients with very short life expectancy. Put them on the neuraxial catheters and give them an infusion just to give their peaceful end of life. And of course, your drug delivery systems, continuous intrathecal drug delivery systems, which do a chemical neuromodulation on the patient and thereby treats the cancer pain. So generally, the interventions is organ specific. Like I would like to divide it into head and neck, trunk and extremity, and abdomen and pelvis. In head and neck cancers, commonly done interventions are glossopharyngeal, trigeminal, and spinopalatine. That the glossopharyngeal indications are more of the tumors from the posterior aspect of the tongue, hypopharynx, and tonsil, and where the extraoral approach of the glossopharyngeal nerve, with the help of the fluoroscopic guidance in the OT, it is done, and identify the styloid process between the mastoid and the angle of the mandible. Hit the mastoid process, just go posteriorly. There comes your glossopharyngeal nerve, and you can do a diagnostic block followed by the pulse radio frequency ablation. And similarly, the trigeminal nerve, anywhere the tumor infiltrates any of the distribution of the trigeminal nerve, we can reach the nerve at the ganglion level near the foramen ovale, and then we can do a radio frequency ablation or even a chemical neurolysis using glycerol. This is an approach like submental view, open mouth view, and the foramen ovale is identified in the submental view, and the needle is reached towards the foramen ovale. As you can see the ovale there, and the depth is conformed with the lateral approach, and it is at the towards the junction between the clivus and the posterior clinoid process, where the Meckel's cave is there, and you can stimulate it with the radio frequency ablate modality, sensory and motor, before you go ahead and ablate the nerves. So this is how it is done, and this is a radio frequency ablator with the facility to have a sensory and motor stimulation before we go ahead and do the radio frequency ablation. So these are all the side effects. Of course, every neurolysis has got, because it's a neurolysis, we are doing a structural lesion to the nerve, so that will have an hyperesthesia, dysesthesia, and if the ophthalmic nerve involved, they may have a corneal anesthesia. There is a 4% chance, and an aseptic meningitis patient comes with the headache. You should know how to deal with it. And spinopalatine ganglion, so much importance on the head and neck cancers. Like most of the head and neck cancers can be dealt with the spinopalatine, because that receives the signals from the mucosa of the most of the head and neck areas and sends to the trigeminal, which is again taken to the brain, thalamus and the brain. So all the type of head and neck, like buccal mucosa, base of tongue, epiglottis, vallicula, lateral border of the tongue, almost most of it can be dealt with your spinopalatine ganglion block followed by an ablation, which has again got a good evidence, which is published in Indian Journal of Pain in 2017. So this is how it is done. Again, a pterygoid approach with the fluoroscopic guidance, lateral, AP, lateral. Final confirmation in the AP view, where the needle tip is just lateral to the lateral border of the nose, and the needle tip in the lateral view should be at the base of the flower vase. It's called inverted flower vase. The tip is that needle tip is towards the as it is indicated in the arrow, it is towards the base of the flower vase, and you can stimulate it. In stimulation, we can have the paresthesia elicited on the root of the nose. That shows we are on the spinopalatine, and then you can go ahead and then you can do a neurolysis. And these are all the complications and side effects of your spinopalatine ganglion. You should know how to deal with it. Most of it is just reassurance, which is most than required. And these are all the challenges we face in treating, in doing an interventions in head and neck, because like you can see a huge tumor sitting there. So reaching the target will be very challenging. Sometimes you may not be able to reach the target as well. So this is an entity, like most of the people we tend to cross without even knowing what could be the reason. The neck dissection is the commonest procedure done in head and neck, where the patient can have a post neck dissection shoulder pain. So we'll be evaluating the cause for the shoulder pain without knowing an accessory. The 11th accessory nerve is involved, and it's a neuropathic pain where you need to treat the patient with the neuropathic drugs. So the truncal and extremities, like we can most of it like can be dealt either by an intercostal nerve block with a catheter inside, or a chemical neurolysis, or a brachial plexus catheter with a continuous infusion. So the indications are again the breast cancer with wall infiltration, lung cancer, the post-thoracotomy pain, where the post the surgery, the neuropraxia or the axontomesis of the intercostal nerves, patient will come with a neuropathic pain along the thoracic dermatomes, and the pain will be worse than the post-operative pain. So we need to deal with the respective dermatomal intercostal nerves and then do a diagnostic block followed by the pulsed or the conventional radiofrequency ablation. So it can be done either by a fluoroscopic method or by an ultrasound method, but with the advent of the ultrasound, the intercostal nerve block made it so easy where we can see the pleura underlying, and we can prevent the pleural puncture, and then we can give an effective block on the neurolysis. And the brachial plexus catheter, as I mentioned, for the pan-post tumor with the brachial flexopathy upper limb pain, we can give an effective ultrasound guided brachial plexus block, infraclavicular approach, and place the catheter and then give a continuous infusion for about a week, break the pain cycle, and then and continue with the medication as a multimodal approach. So again, an article in Pain Physicians in 2015 published nicely on brachial plexus block with the catheter in a cancer-related pain, very promising. The case series published. So now comes to the sympathetic block. So somatic, as we discussed, 4 types: somatic, sympathetic, neuromodulation, and neuraxial. Sympathetic blocks cover most of the low abdomen and the thoracic malignancies. The stellate ganglion takes care of head and neck arm pain due to cancer. The thoracic sympathetic T1 or T2 neurolysis takes care of thoracic malignancies. And upper abdominal visceral pain, the splanchnic with celiac plexus ablation. And the lower limb pain could be, as Dr. Raghu Thota said, the chemotherapy-induced peripheral neuropathy can be dealt pharmacologically, and in case of very severe pain, you can deal with the lumbar sympathetic chain as well by doing a pulsed or the conventional radiofrequency ablation. And the lower abdominal and the pelvic malignancies can be dealt with the superior hypogastric plexus, and the perineal or rectal pain with the ganglion impar. So this is a stellate ganglion, again is a subfacial block, can be done either using in ultrasound or fluoroscopy. But in my experience, ultrasound is better, being the subfacial, being a structure in the subfacial plane, easy to reach, stimulate, and then you can do a ablation. And the thoracic sympathetic chain T1, T2, again, fluoroscopy is better because very difficult to perform an ultrasound guided thoracic sympathetic chain because of its deeper structure placed. So with the fluoroscopy at T1, T2, AP lateral depth and direction confirmed, and stimulate it, and then go ahead and do the ablation for the thoracic T1, T2 sympathetic chain for thoracic malignancy. And celiac plexus was covered by Dr. Muralidhar Joshi, and it is again a plexus ablation done for upper GI malignancy, which is placed just in front of the aorta. The L1 vertebral body can be approached by retroperitoneal posterior approach, or retroperitoneal transaortic approach, or can be an anterior approach as well. This is a picture shown is like retroperitoneal, retrocrural approach from the back. The L1 anterior vertebral body reached, and then the contrast is injected and spread for the linear spread of contrast without dissipating to confirm it is not in the aorta, and then block it with alcohol and local anesthetic mixture. And celiac plexus block can be done effectively using ultrasound guidance, like just to follow you cannot miss out the cross section of the aorta in the ultrasound, and once the cross section of the aorta is found, we have to just go and see where it gets branched out. The first branch is your superior mesenteric and your celiac. Celiac is the first one. So the celiac divides into again the hepatic and the splenic. We call it as a seagull sign or ram's horn sign. Just on either side of the horn, what you inject is the celiac plexus. It is again one of the block effectively performed using ultrasound. And another advantage, as Dr. Sushma Bhatnagar mentioned, it is a procedure can be done as a bedside in a patient who cannot be shifted, or in a terminally ill or end of life care and hemodynamically unstable. You can do it in the bedside, and after explaining the risk to give a good pain relief. So splanchnic nerve ablation is it's complemented along with the celiac plexus for upper GI malignancy, targeted at the T11 vertebrae and AP lateral, and the needle tip is placed exactly at the confirmed at the junction between the anterior 1/3 and the posterior 2/3. Again stimulate it and ablate it at 80 degrees for 3 seconds. Superior hypogastric for lower GI malignancy and pelvic malignancy. The posterior approach, the needle target is at the L5S1 disc space, and the approaches will be retroperitoneal, bilateral approach, 2 needle technique, or a transdiscal single needle approach at L5S1 that will reach the L5S1 through and through L5S1 disc space and reaches anteriorly, and then your alcohol and local anesthetic can be injected. So this is how it is, and the needle tip is exactly above the sacral promontory in PA view. So this is a ganglion impar ablation, which is at the sacrococcygeal junction. The sacrococcygeal junction disc space will be seen in the fluoroscopy, and then with the needle through the disc space reach the sacrococcygeal junction, and then inject the contrast. Make sure we are not in the intrarectum, and confirm the contrast spread and do a stimulation, and then do a radiofrequency ablation, which has got a wonderful systemic reviews about the sympathetic blocks published in Critical Review of Oncological 2015 and in Pain 2004 about the effectiveness of these blocks and how it modulates optimizes the medications for cancer pain. This neuraxial blocks is an entity ideally suited for end-of-life patients, where like a routine epidural is placed on the patient and the catheter is placed, and from outside we have to give the local anesthetic or morphine like how we do for anesthesia. This is for patient near the end of their life, or a subcutaneous intrathecal catheter and an injectable port connected to an external pump. This is recommended for patient with life expectancy of 1 or 6 months. If the life expectancy we think more than 6 months by your clinical examination, then ideal would be your IDDS, which is an intrathecal drug delivery system, which is more effective, and then the drug given is 1/300th of the dose of the opioid what we give orally, with a very less systemic side effects of the opioids. So that is your Synchromed 2 Medtronics gives, and little expensive, but in long run, if the life expectancy is good, the pain relief will be excellent, and then the patient will really enjoy the good quality of life. So this is how it is placed. The needle, it has got 2 components, the catheter component and the pump component. The catheter component is placed at the entry point is at L1, and the tip will be decided, that placement of the tip will be decided on the type of the cancer and the site of the cancer. But it can be placed anywhere until the cervical. So from the neck till the periphery, till the foot, it can be placed, except for the head and neck cancer pain. It can be used for any other type of cancer pain. And then the catheter is connected to the pump, which has got a reservoir, which is the quantity of the reservoir is 40 ml, and the morphine and the zigotinide or the drugs can be used as the drug of choice for pump filling. So as I mentioned, the advantage is it is 1/300th of your oral dose. So thereby the systemic reaction of the morphine what we use in the intrathecal pump is very less, almost negligible. So where the patient will not be succumb to the adverse side effects of the opioids. Again, which has got a good review. This is a multi-center product surveillance registry maintained, and it is published in Anesthesia and Analgesia in 2020, where you can make a note about the pumps, the intrathecal pump placed for breast cancer, colorectal, pancreatic, prostate, and bladder, effectively done, and then has got a good follow-up, and then good quality of life, which has been enjoyed by the patient. So that's a nutshell about the neurolytic procedure, and briefly about the future. This is one which really impressed me about a rat called neck mold rat. I think a lot of research is going on this rat, because this particular rat is completely pain insensitive. You can put the needle, you can put the knife on an alive rat, and they have proved there is no nociceptive substance released because of any painful stimulus done to the rat. So there is a lot of research is going on what is the cause for the pain insensitivity of the rat, and then that is really going to help us in making some pain products, either pharmacological or intervention, to treat the pain. And of course, cancer pain is the worst. And this particular part is cancer resistant also. So there is something to do with genetic mutation, and they induced a lot of carcinogens onto this rat, and they could not reproduce any cancers on this mole rat. So a lot of research on cancer pain going on with reference to this naked mole rat, and then the University of Cambridge is conducting this research, and I'm sure like we will get something out of this. And the take-home message is the strategy that is more important than just a single weapon, and earlier is the best. So it is like a Trishul view. In Mahabharata, there are several views to defeat the enemy, and cancer is one of the worst enemy what we have. So we should have a view to deal with the cancer. So it is always multimodal. It's not one modality that can win the cancer. So it's an intervention, and it's a pharmacology, and it's a radiation, and it's a non-pharmacological complementary therapies like psychological therapies and aroma therapies and behavioral therapies. So it's a multimodal approach and strategical approach that is going to win over the cancer pain. So let's take the bow in hand to kill the cancer pain. Thank you. Namaste. Can you hear me? Dr. Neeraj is here. Hello, Dr. Neeraj.
Hi, my pleasure, Dr. Anand. Good job. And it was a good conference in totality, you know. Little extended, but it's nice. Lot of message, you know. Lot of carry-on messages.
Yeah. For the audience, for the delegates, I would like to introduce Dr. Neeraj Jain, who is a very senior interventional pain specialist. He is a senior consultant interventional spine and pain specialist in Pitampura, New Delhi. He is an in-charge pain clinic, Balaji Action Medical Institute, New Delhi. He is an in-charge spine clinic, Max Hospital, Shalimar Bagh, New Delhi. He is an in-charge spine and pain clinic, Akarsan International Hospital.
Well, I'm all your friend, you know, to begin with.
He's a very a mentor of mine and my senior of mine. We got our fellow FIP and SIPs together, and I would like to get inputs from Dr. Neeraj Jain on this webinar, and also he can add up few inputs about the topic as well.
Now, first of all, my compliments for taking up this topic and doing it in such a big way. You know, it's a very big way. It's good, and you really covered a wide range of pain management. You know, especially in cancer population. To the few messages just for my friends who were sitting around, and this is the point is you should empathize with the cancer pain patients. You know, and put yourself in the same shoes, and they understand how big is this pain. This cancer pain is a real pain. And you can really do a good job, you can really do good pain relief, and the whole family, it's not just the patient pain, it's the family pain per se. And you see what happens is most of the time you hear, like Dr. Ram Pasupuleti was saying, his friend has died. See how much pain he was in. We have to perceive that pain, he was so empathizing. So it's a family which carries with the pain, the patient dies and the family stays in pain for a longer time. So if we can take care of this pain of the patient, the family pain is reduced to the minimum. So we empathize and try to reduce the family pain, and they feel most obliged. Any treatment they have gone through, radiation therapy, onco, surgical therapy, but they feel most obliged therapists, the people who are taken up with the pain at the end of life, because all other treatments have failed and your pain treatment has passed. So that is what people feel most obliged. So please be there for the end of life care, and be a rescue person for these also for that matter. And the few tips for the procedure per se. It's about the celiac and the splanchnic blocks. People will be talking sometime it failed because of the late presentation of the part of the patient, or because of the varied anatomy, or because of the surgery being done. So what I normally do in these patients is I put 4 needles in the floor room, and I've been telling the people earlier also, I do a multi-firing. So when you have in doubt, you take a machine gun, so everybody dies. So I do a multi-firing, 2 needles at the celiac plexus at the T12T1 D12T1 junction, and one may be pre-aortic. I might take it just in pre-aortic, and so the 2 needles at the splanchnic. I put those 4 needles in this C-arm room. Now cover my patient and take the patient. My CT room is just next to my OT, and take the patient to CT room now. Let's check those 4 needles now. Where are they really located? Put in half ml dye at each level. See which are best suited needles, 1 or 2 needles, or do a little adjustment now. Your 4 needles, I would always prefer to take 1 needle ahead of the aorta. Like a typical, you open the stellate, see the blood coming through the aorta when you're going through the aorta, and then so the blood stops coming and you are through the aorta, you are in pre-aortic now, and that's your best needle to put your drug in, and you put 10 ml of the neurolytic agent, be it alcohol or phenol of your choice. And I do put I populate all those 4 needles with my medication. Now let me tell you why. Because it has been seen. We have been talking about the best block. We are talking about 80-85% of the success rate. Why not 100%? Reason because there are few escape nerves which escape the your drug and they are still causing pain. And I don't want these patients to come back to you again because it's the end of life. They have only 1 month left, 2 months left, and you're the last person, last procedure, they are going for. So you give your best shot there. It's like you're straight away made to run for Olympics. You give your best shot. You cannot, take a long time like in other chronic pain scenarios. Give your best shot, do 4 needles, populate all the 4 needles, don't leave a single nerve for pain to carry thereafter, and there's no harm. You see, all these are very safe procedures, except you keep telling them about postural hypertension and diarrhea which may ensue over a period of time. You normally take good care of that also. So I always say multi-firing, 4 needle, do little extra when it's end of life care. Don't go for the protocol thing and go lower in the scale of the procedure. Go higher in the scale of procedure. This is one of the leads I am trying to say. Second is about the C2. You showed a very good picture of the tumor here. So when there's angular mark tumor and all, when you're doing a trigeminal block, C2 block really helps you in these patients. Very, very helpful. So C2 block, learn this, very useful block, and you can take good care of pain in these patients who have got angular mouth pain. About the rectus spinae pain block and the parietal block, I say anywhere if there is a cancer pain in the torso region, be it lung or be it rib, be it chest cage, be it the abdominal parietes, there's no point of leaving the patient in pain because you can take these 12 nerves safely out of the body, safely. So you have whether do intercostal block or a rectus spinae block, or you do a parietal block, or you do epidural neurolysis. I go even and do intrathecal neurolysis with a very, very good result in CA lung patients. To the extent that patient have been telling after the procedure, doctor, get my CT done, my cancer is cured. So this is the beauty of these procedures. Don't leave them in pain because it's really in your hand and you can give this good shot. So go for a 6. Many of these patients come for epidural catheters. Yes. We were talking about the intrathecal big pumps which are costly. But here in India we have Baxter flexometric pumps, or other pumps. And you put in a catheter, you can have this. I've had patient 4 months with the catheter on, with the pumps on, external pump. One pump may work for a month. You give them a stop clock, and you give them a 3-way cannula, 3-way attachment, and you tell them, you use it half an hour, 1 hour as soon as pain goes, stop it, and then you put it on when the pain comes back. And that works maybe once or twice a day will be good enough. Morphine with the LA, with the sometime ketamine, sometime other drugs you put in, clonidine and all, depending on what kind of pain patient has got. Neuropathic pain or nociceptive pain, and it gives a wonderful relief. So these pumps are good for last 4 months, and that's what you normally get with these patients, and normally they are gone by that time. So this is what it is. People have been doing C2 cordotomies. I'm not for that, but yes, people who can do it, manage it good. I've done initially in my career, I've done a pituitary ablations. We call it chemical hypophthalmectomy, transnasal transmural pituitary ablation, or chemical hypophthalmectomy. Very good for prostate and breast cancers, and the neural mats, like spinal cord mats. Very, very helpful in those patients. And this is a very wonderful procedure. But be it any procedure you do, go all out, do your best, put your best foot forward, and hope for the best. And it's a continued care. It's not one time. You said it's only today. It's today, tomorrow, and ever. You give relief to these patients. It's a wonderful job done. My compliments to you, Dr. Anand, and the whole team and others.
I have a few questions to you, Dr. Neeraj.
Yeah, definitely. Another thing is which I want to say one word is ultrasound is your external eye now. You're doing an ultrasound. It's a beautiful tool, and people have got a handheld ultrasound coming now. You can put it in your pocket and you go at any patient ward rounds and all. Beautiful tool. Make best use of it. It was a good talk. Focus was a good talk again.
What's your experience on intrathecal neurolysis?
It's a very, very good. You do from T2 to somewhere around T11. Or something like T. When I say T12 is the nerve, but when you go intrathecally, you go from T2 level to T7. Because thereafter the lumbar plexus starts. Intrathecal, I'm saying, not epidural. Intrathecal. If it is epidural, you can go to the level also. You can go even D12 because it is epidural. intrathecal because the whole medulla and everything starts, the conus starts, and you have to stay above T7 to do your intrathecal neurolysis because the nerves come out 1, 2, 3 segment below. So I go inside, put a needle at the middle segment. Suppose it is D4, 5, 6. I put one needle at D5, the interlaminar tract typically, go intrathecal on the side of the lesion. Remember, on the side of the lesion. And now on the side of the lesion, put this lesion. I use alcohol mostly. People have used phenol also because then you have to make it dependent, which is more difficult to manage. And managing it kind of other way around is semi-prone position is much better. So I take my needle in on the side. Suppose it's right side lesion. Put needle onto the right side. Put right side up now and semi-prone position, not just lateral or prone, semi-prone, and put my alcohol through this needle 0.1 or 0.2 ml with the insulin syringe at one time. 0.1, 0.1 and 0.2 ml at one time, very slow. And now you just put inside over 10 seconds, wait for another 10, 15, 20 seconds, put another 0.1, 0.2 ml. You can inject 1 to 1.5 ml at each level. Suppose 3 levels are involved, you can go in for about 3 to 4 ml, and according to your patient, head up or head down, depending on. Remember, it is hypobaric. Remember, if it is cephalic, you're putting head up. If it is a caudal, you want to put it the foot up, and that adjustment can be done in 45-degree bend because you want to take only the sensory nerves. You don't want motor to go. So that's what can be semi-prone. Only sensory roots are bathed and DRG is taken care of. The pain is taken. It's a beautiful modality. I've got a very good response. But it's a very important that you do it right. Yes. Suppose you load the drug in one go, then it touches the cord and the whole long tracks are gone and all blood gets involved. So this is the lead. Remember, second thing is there is acute excruciating pain once alcohol touches the nerve, bare nerves, inside the intrathecal space. Keep this thing ready. You can give a little of sedation, a little of propor, something, but you should be ready. Patient will once wins the pain. Or if you want to give it a local, it's a choice. But then the problem after giving local is then your lead is gone, that it is working or not. That's the only problem which I have done earlier. I used to give local and then put in phenol, now alcohol, and you don't know whether it's working or not. So if you can patient tolerate some pain with under little anesthesia, wonderful. If not, you can pre-mix alcohol with LA also. So that will dilute the alcohol, remember. So we don't want to normally dilute alcohol. So you can pre-treat with LA and or some sedation and then do a little alcohol. It is absolute wonderful procedure, intrathecal neurolysis. I would advocate all pain guys like you are working in a cancer center. Any torso pain you can take care of in this patient with intrathecal, and plus if it is a little lower down, then you can use epidural phenol or alcohol is a call. You can take a call. It's wonderful. And then obviously paravertebral lately erectus spinae pain block is also very good thing. So that we say is very good thing.
And the role of interventions in skeletal pain due to metastasis. To come across the skeletal metastasis where the patient's pain score is very severe than the visceral pain. I somehow feel the bone pain due to cancer is worse than the visceral pain. And a lot of time we fail to give them the good relief. Is there any role for intervention in bone pain and bone metastasis?
No, there is a problem. If it is long bones, it's a problem. Was it a spinal area? You can always do the needful. You can always do all these procedure. Even for the spinal mats, I can go and do an epidural neurolysis. It works good for the given level. Suppose it is D7 fracture. You do D7 neurolysis, the pain is taken care of, and same can go even lower down. But when it comes to long bones, it is a problem. There is a very big problem. Sometime for the hip pain or pelvic pain, I have tried the erectus spinae pain block. It works good. There's one article today, ESP, lumbar ESP. We are not talking about the thoracic one. The lumbar ESP also pain block. It works good for even for the bone graft, iliacus bone graft. So that way it works great. But yes, there are few other procedures we can try a local. Like if it's a hip pain, you have a hip, like you do a genicular RF, another RF, and hip RF. You can do those things. That can be done a local pain blocks you can do. But the only problem is when you go for the main roots or intrathecal for the lumbar plexus, then the motor is going. So you always tell your patient, either we have this much pain or we are trying a little of those blocks and we are trying to do a differential block, good. If it is so much so that you can't manage, and always try other polypharmacy, always try fentanyl patches, always try other drugs. And why I don't understand people don't try diclofenac. I don't understand. Patient is left with 1 month or 2 months of the life, and we say, okay, we won't give you overall diclofenac or diclofenac patch. You can give it for that matter. Not even the oral ones, so the patch or injectables, because your kidney might go. What is this? Kidney will go in about 2 years time or 1 year time, and patient is dying in this 1 month time. What we are waiting for, renal issue. So there's no problem. I am of the opinion, give strong NSAIDs if it is end of life care, along with the fentanyl or other patches you want to give it. Even these patches are also available. Suppose GI concerns are there, you can use patches. Use 2 patches. One patch is fentanyl, other patch is diclofenac patch, new patch or diclofenac patch. Use those patches, and now rest I can manage with the polypharmacy, whether neuropathy medicines or other medicines, and some blocks. If I find like celiac works great, I'm not going to leave celiac block and wait for this. No, that will be my first go. And then you along with us, I do other drugs. So minimize the pain. Patients are comforted. I've had many instances, patients come walking back to me with the thanks. And there have been instances where I put a catheter on and patient died, and people came back with the thanks call or gave me thanks call. The whole idea is you're doing a human job. Please understand, it's not just a job. It's a soulful human job on our part. We are lucky that we can give relief to these patients who are really dying. It's a disgrace on part of the nature why these people have cancer and then cancer pain. So please, let's correct what we can do at our end. It is doable, we should do it. Yes, there have been some time, like if it is shoulder pain, I won't leave suprascapular. I would definitely do it. Axillary, suprascapular, and later pectoral. I definitely will do it, because you're not going to lose anything and you're not big worried about the pain. I've had instances, let me give example. Patient had a CA breast, lymphedema in the arm. Patient has come with the request, cut my arm away. It's painful, it doesn't work, it's painful. It doesn't work at all, it's painful. So please cut this arm off. So I have done even brachial plexus neurolysis. Please, this is long time I'm not doing it, but I've had instances where they differential block, like 3% or 4% of phenol. The whole brachial plexus, like we do brachial plexus block. But yes, it's not advisable. You can have catheters on, you can manage the catheters. Wonderful things, these all are doable things. Yes.
Thank you, Dr. Anand, for your great input. Any questions for any speakers? Anyone has got any questions? Yes, Anandakumar.
People have had enough of knowledge today, so they probably.
I want to know about that epidural catheter, sir. You said about a epidural catheter that we can put for the patient for 4 months, no? What is the name of that catheter and where we can get it?
No, see, these are intrathecal catheters which are available with the V Brown,
Okay.
Intrathecal catheter. Same catheter can be used in epidural. I have even used the Potex ones, the epidural catheter, and you tunnel it. Once you tunnel the catheter, your tunnel is very, very, very secured catheter. I've used this catheter without any infection, without any problem, and by God's help or grace, I initially used to give 1 week of antibiotic with the catheter on, and thereafter I've never had to use antibiotic. Yes, they have to take care of the port, what external port now which is coming. You always put a filter on. The external port has to be kept in a sterile packet and always be taped in the body with the sterile gauze on. And once the catheter coming out of the body, you always stitch it, and then this area where the catheter is coming out of the body has to be kept sterile. I've never had the infection with the catheter. I never had to remove catheter because of the infection. So this is the beauty of these things. Try these things. 3-4 months left. You can manage the catheter instead of putting a big pump on, which is costly and people don't like that kind of thing. I found catheter to be much more versatile, and you can change your drug combinations. Like if I put a pump on, I put 3-4 drug combination, LA and plus any narcotic like fentanyl or morphine, clonidine. Sometimes do use midazolam. Sometimes use even ketamine and other drugs. I used to use neostigmine also for some time. And with these drug combinations, you can always permutation combination these drugs accordingly. And people keep 2 pumps. One pump is only 3,000 rupees. One pump is filled, one on the patient, and once it's about to empty, I fill the second pump to them and give it to them. And they keep one filled pump with them, so they're not at loss with the drug. The pump is not off any time. Initially, they have to put pump, half an hour, 1 hour, twice a day, which works for 12 hours because morphine gone inside epidural works for a long time, or intrathecal works for 24 hours sometime. But later on, when the disease advances, you might have to keep pump continuously on. The consumption increases at the later stage of the malignancy. Initially, it is only once or twice a day, half an hour, 1 hour. That's good enough. So I have had patient who has come after a month for a refill. Later on, they might come weekly for refill. But then you keep 2 pumps and you rotate between those 2 pumps.
Thank you. Very, very fascinating and informative. So we come to an end of this webinar on Wednesday. And any questions? So may I thank all the speakers in spite of their schedule. I know like everyone is tight packed with their schedule and giving their time is something very precious. So I thank Dr. Sushma Bhatnagar, Dr. Neeraj Jain, Dr. Ram Pasupuleti, Dr. Muralidhar Joshi, Dr. Carina and Dr. Raghu S Thota for their time given to us and enlightening the crowd about the cancer pain, which is the need of an hour, and we have to take care. That is the least we have to do, and that is the must we have to do for cancer survivors. And finally, would like to thank the administration, Mr. Harshad Reddy, who is the director, and Mr. Dinesh Madhavan, who is the CEO of Apollo Oncology, and Mr. John Chandy, the CEO of Apollo Proton, and Dr. Rakesh Jalali, who is the medical director of Apollo Proton Cancer Centre, and Dr. Srinivas Chiliguri, who is the WOW series in charge, and my senior and junior colleagues and my all postgraduates. Thank you one and all for attending this webinar on Wednesday, and see you all in another webinar. Thank you. Have a good night.
Thank you, Anand. You have done a marvelous job.
Thank you.
Good job. Good job. Pleasure. Thank you, my friends.
Thank you so much.
Thank you, sir.
Thank you, Karina. Thank you. Good job. Good talk, Karina. Good talk.
Good job, Dr. Anand.
Thank you. Thank you so much.